My name is Kathy Malejczyk. I'm one of the medical microbiologists in Regina Cappelle Health Region, and I guess I've been asked to present about microbiology reports and how to kind of make them more meaningful, or as meaningful as they can be in terms of interpretation. So here we go. So briefly, just to outline the objectives, we'll talk about the limitations of the micro report. And there is a little, sorry, a pop-up.
Reconnecting here?
Oh, should.
Sorry.
Says we're still on.
Okay. So, sorry, limitations of the micro report. We'll focus basically on bacterial reports, culture reports, just because it's the majority of what the micro lab does, and that's where your interpretation is necessary. So we'll talk about that. We will talk about microreports in the context of normal flora. We're not sterile, and it's in everybody's benefit to know what normal flora is. We'll also outline the power of the gram smear, a test that's been in existence and used unchanged for 133 years. So it is a powerful test, trust me, and hopefully I'll convince you of that. And highlighting the fact, obviously, that all of this should never just be taken at face value. The results from whether it's microbiology, chemistry, etc., always need to be interpreted in the clinical context. And then we'll have some, hopefully, time for practice cases. So why are we here? Why is this important? What will this information give you the ability to be better at? And so bottom line is that the more you know and the more you internalize this information and put it into your practice, obviously you will be providing the highest quality of patient care, which is our ultimate goal. You're also ensuring patient safety by decreasing unnecessary antibiotics and obviously preserving antimicrobials, and then ultimately decreasing the rise of antibiotic-resistant organisms, which I hope you all know that are definitely on the rise, and we are facing kind of an apocalyptic end of times kind of message related to antimicrobials, in the sense that we know that sooner than later, unfortunately, there are fewer and fewer antimicrobials, and people are actually dying from having infections that are unable to be treated because of organisms that are resistant to all the available antimicrobials that we have. So it's important things. But, when I list this, this really in a nutshell describes the antimicrobial stewardship program. And by practicing those things, you are then the stewards of antimicrobials as well. So yes, we have a program, but it's in our hands to be the stewards of those drugs. So this is just to put things in perspective, an example of how things can actually go wrong. This is a case of a 35-year-old gentleman who presented with a rash on a leg to his primary care physician. The rash was basically just a red, maybe some blisters, but not weeping, not purulent by any means, dry looking, red, but not hot, inflamed in any way. So swabs were taken, and the patient was started, believed to have an infection, and the patient was started on Keflex or cephalexin. The rash was not improving, so the patient came back to his physicians, and the report that was sent from that swab indicated the gram smear showed no polymorphs, 3+ epithelial cells, no red blood cells, and no organism seen on the initial gram. And cultures from that swab actually showed Staph aureus, which turned to be MRSA. Therefore, the only antibiotics that were reported as susceptible were Septra, Clinda, and vancomycin. And the question, I guess, for you, and feel free to press the microphone button or just raise your hand, and if you're here, to just answer the question, what would you do next? Change the antibiotics, refer them to the emergency department, continue to monitor and not do anything, or consult a colleague. Anybody who's brave enough to answer? So I heard monitoring, yeah. Monitoring is, I think, an appropriate step, yeah. Anybody else?
So why would you change the antibiotic?
Why would you change the antibiotic? So currently, remember the patient was started on cephalexin, and Staphylococcus aureus, the MRSA variety, is not susceptible to that. So it's actually resistant.
Why would you change it?
So I guess that is kind of the question of, should you change the antibiotic, or what is the meaning? So I'm getting at the kind of the interpretation of what's going on if you're the clinician. So yeah, you're right. I mean, you should change the antibiotic, and perhaps that is the answer. But I'm just feeling for what would people do. So some people would change the antibiotic. Some people would just watch and wait. So as per this clinician, antibiotics were indeed changed to cover MRSA. And because the patient had sulfa allergy, the antibiotic of choice as an outpatient was clindamycin. But the rash did persist. The patient did develop worrisome symptoms of a SIRS-like picture and was bad enough to actually warrant an ICU admission, upon which he was started on vancomycin to again cover that MRSA because of the severity of his condition. He did develop abdominal pain and diarrhea, and colonoscopy performed that same day revealed membranous colitis, and stools that were sent off were positive for Clostridium difficile. And so, unfortunately, that same day, the patient actually had an emergency colectomy. And the moral of the story, well, the rash overall was likely not of infectious etiology. Antibiotics were really not necessary to begin with. So even the Keflex that was started for a rash that appeared, red, blistery, not purulent, not hot, not tender, were probably started inappropriately or excessively. And Staph aureus is a pathogen. It's a well-recognized pathogen in the setting of skin soft tissue infection. However, it's part of normal skin flora. So when we talk about the gram stain, how it's interpreted, I'll kind of show you why I think in this case Staph aureus was just a bystander, a normal skin commensal that, of course, were not sterile, so it came back as positive on the report, but indeed was not the causative agent of infection. And on admission to ICU, the MRSA was assumed to be significant because of how severe the patient condition was, which is absolutely appropriate. But ultimately, the inappropriate antimicrobial prescribing came at a cost of a colon, and the morbidity and gained as a result of that was obviously a horrible outcome. So what are the current problems with antimicrobial prescribing? Well, it's multifactorial. This is a practice that is both a problem in hospital setting as well as in a community setting. And there are multiple reasons for why this is happening. There are obviously patients and families requesting for their loved ones to be taken care of and prescribe antimicrobials for what they seem or deem to be infections, whether it's a UTI or a respiratory tract infections that may be viral. They insist on having antimicrobials. The prescribers themselves may have a belief that the antibiotics really are an easy fix, so there's no harm. I mean, it's something that I write, the patient is happy, I'm happy, the patient's out of my office. The perceived lack of side effects of antibiotics clearly, the benefits clearly outweigh any risks associated with antibiotics, which is in itself a false statement, is what drives the inappropriate antimicrobial prescribing. And in some cases, or in many cases, it's a lack of knowledge about infectious diseases and etiologies. It's the lack of knowledge of antimicrobials, period. It's lack of experience, personal experience with antimicrobial side effects. And in very few cases, unfortunately, there's a lack of insight that there may be a lack of knowledge. So people are prescribing thinking that they're aware and understanding of what they're doing, their practices are, but in where in fact that is not correct. So I think over the last 5 years, we've seen a lovely change in the respect that there is increased discussion about what are we treating with. There's a question: is this the right antibiotic? Should we go, to a different antibiotic with a narrower spectrum? So I think we're having very meaningful discussions already. But I think the important part now is to move forward, or in this case, back one step and pose the question, should we even be treating this? It's kind of the next evolution in how we think about antibiotics. And this, again, is important because we're seeing increased antibiotic resistance. And the only way to combat this is to prevent antibiotics from being utilized in settings where they're completely inappropriate. So, hey kid, want to be a superbug? Stick some of this into your genome. Even penicillin won't be able to harm you. And so this is the member of the antibiotic resistant approaching little Albert, the Staph aureus, passing through a hospital kitchen and on wanting to become the superbug that we know as MRSA. So this is happening, and it's happening both in the community and in the hospital. So should we treat this? It's a big question. It's a very, for many, it's a question that they're almost afraid to ask. It shouldn't be viewed as undermining the prescriber's authority, whether it's a nurse practitioner, whether it's a physician, whether it's a pharmacist. It should be viewed more positively as a chance to reassess the patient condition and to reconciliate the meds, in this particular instance, looking at antimicrobials. So in the literature, this is known as a mindful pause, and it's been greatly shown to be greatly effective for aiding appropriate antimicrobial prescribing. So that's what I think we should all really hope for, as having a supportive enough environment to be able to ask this question, knowing that this is something that we do for the sake of our patients, and not, walk a fine line of, maybe overstepping our boundaries, because ultimately it's the patient that will benefit from this mindful pause. So before we, I think in order to then be able to start to have those meaningful discussions, we need to know what the limitations from the laboratory side are of the micro report. And so there are a couple of assumptions that are made by the microbiology lab. One, that there is a clinical suspicion of infection. And so again, infection, when it comes to microbial or bacterial infections, where there's purulence, where there's redness, where there's heat, where there is tenderness at the site of infection, or whether you're talking about cough, an area of consolidation with increased productive cough, associated fever, etc. So that's one assumption. Also, that specimens are obtained prior to the start of antibiotics, and that is so that we assume that we've been given the specimen, and if there is a pathogen, we will recover that pathogen. It has not been treated or killed by the antibiotic that the patients are on. So highest quality of specimen in that regard. And then in terms of the highest quality of specimen that is appropriately collected and submitted, transported to the lab, is the number one example that comes to mind is, in the setting of opening up or draining a large abscess. We often get a swab of an abscess fluid, whereas it's way more valuable to then, draining 500 cc of abscess fluid, just submit the actual fluid itself, as opposed to a swab sampling of that fluid. So again, intraoperative specimens of INDs of incision and drainages of these abscesses, we often get just simple swabs, whereas really the most high quality specimen is the actual drainage fluid itself. And then we also assume that the specimen source is correctly labeled. This is extremely important just because different areas of the body have different potential pathogens. And so if we are looking at, a swab of a lower leg, those pathogens might be slightly different than, for example, your sore throat. So if we know the actual specimen source, we can tailor our workup of the specimens or closer to actually be able to find and isolate those appropriate pathogens. And of course, we don't get clinical info a lot of the times, but it is essential for appropriate workup of a specimen. And the example I can give you for that is, having a swab of a leg ulcer or a leg wound is going to be, we will look for much different things when we know it's coming from a necrotizing fasciitis case versus a chronic ulcer in a diabetic patient. So again, that clinical information only aids us in the workup. And so whenever you can, please provide it. And then I think the assumptions, it's important to note that there are also assumptions made by the prescriber of the antibiotic, and that whether we recognize it or not, it's clearly illustrated that once we report an organism with a susceptibility attached to it, it's immediately seen as a pathogen, as something significant, and that obliges the prescriber to then prescribe the antibiotic and treat it, which is not all, well, many times it is the case, but again, it has to be interpreted in the clinical context. So, in many times, it is not the case. So, be critical of the report and of the perceived pathogens that we are reporting out. And so this is a slide, and it's not meant for you to be able to read it. It's more for the even visual image of these are obviously this is your body, and these are the different sites that bacteria are on your skin, in your gut, ears, digestive tract, etc., respiratory tract. We are not sterile, and so any type of specimen submitted will grow something. We try to interpret that and sift through that, knowing what normal flora in these sites is. But in the right setting, any organism can be a pathogen, and any pathogen can be a simple bystander, a colonizer that is actually not doing anything and therefore does not have to be treated. And so if I could point out things like Staph aureus, are part of, it's a known pathogen of skin soft tissue infections, but it is part of normal skin flora. Pseudomonas and gram-negative bacteria are part of normal flora in the lower areas of the skin, on your legs. E. coli and other gram-negatives are part of your normal urethral flora because, again, patients are colonized with these things prior to them actually causing urinary tract infections. So the fact that we merely isolate a pathogen from a site does not necessarily automatically indicate that they are truly playing a role in disease state. And so I think it's important to really know what normal flora is at different sites. But again, going back to what I said as the most kind of important point is that the results must really be interpreted in the clinical context. And I think that's a very important point. Also in the back of our minds, it should be always having the consideration that there are obviously non-bacterial etiologies for common presentations and altogether non-infectious etiologies that we must be mindful of and not jump to the conclusion that, hey, this rash must be bacterial or infectious. So we know that viruses, especially at this point in time in the year, are everywhere, and they do have a travel agency, I bet, and if it looks anything like it, doorknob and computer screen or computer keyboards are probably their top two destinations. So let's look at deconstructing the micro report. And the Gram stain is powerful. As I said earlier, it's a test that has not changed over the last 133 years at all. And so that, I think, just shows how useful it is since it hasn't really been eliminated or altered over a long period of time. And whether you're talking about Mayo Clinic or, a little lab in Timbuktu, the Gram stain is being used just the same. So why is it important? Well, it's the first report that is generated. It gives you a kind of a snapshot of the microbiologic flora of that area, whatever the specimen comes from, in vivo, so in the patient at the time. And this is just an example of how one might look like. It gives you the degree of purulence, so reporting on the number of PMNs and white blood cells, as well as, importantly, it gives you the bacterial amount present in situ or in vivo. Whether or not the bacteria are dead or alive, we don't know. At this point, it's just whatever you see. And then bacterial morphology, so gram-positive cocci, gram-negative bacilli, etc. But again, the need for this, it absolutely has to be interpreted in the clinical picture. And what I mean by that is, for example, if we consider a tissue from a leg, it's a surgical specimen, which shows no white blood cells, 2+ red blood cells, and 1+ epithelial cells, and gram-positive bacilli. So is this meaningful? What kind of information could you extract from that? Or what does it mean to you? And feel free to participate. So what would you think about gram-positive bacilli? Can you throw out some names?
The BP frag.
Bacteroides fragilis is gram-negative. Actually, it's an anaerobe. But so gram-positive bacilli could be Corynebacteria, could be Lactobacillus, or it could be Clostridium. So again, the question is really relating it back to the clinical condition. How sick is the patient? Is this specimen from a patient who has necrotizing fasciitis, where you kind of think, oh my goodness, I see gram-positive bacilli. This may be Clostridium perfringens causing the necrotizing fasciitis, or is this a diabetic ulcer that is being debrided with gram-positive bacilli, which could be Corynebacteria, part of normal skin flora. So again, the context will alter what you can what kind of information can be taken from a gram smear. So Clostridium perfringens versus bacillus, depending on the patient condition. And as part of the, our work in microbiology, we try to communicate certain aspects of bacterial morphology to maybe be a little bit more suggestive without sticking our neck on the line of saying, based on the gram smear, which, as you all know, is a preliminary report, or it's a kind of a first look at the specimen, it is preliminary and it should be taken as that. But so without sticking our neck on the line, we try to communicate what the likely or the potential ID of an organism could be. And these are just some of the kind of hallmark statements that should point you or should make you think about a particular organism in these particular instances. So a gram-positive diplococci in sputum, what pops into mind? And this is kind of what the gram smear could potentially look like. Strep pneumo, perfect, exactly. How about a gram-negative diplococci in CSF? Meningococcus, right? Neisseria meningitidis, perfect. Again, knowing the clinical context, so based on the type of specimen, what would a gram-negative diplococci from a penile discharge be? And yeah, gonorrhea, right? So Neisseria gonorrhea, absolutely. And what if you have a gram-negative diplococci in a sputum? So it could be Neisseria meningitidis still, but more likely probably is Moraxella. So again, knowing the gram stain, knowing the type of the specimen and the clinical situation can really give you a lot of information about what you may be potentially dealing with. How about gram-positive cocci and clumps in a blood culture? What would you be thinking about? Staph aureus, or staph of some sort, whether it's Staph aureus, whether it's coagulase negative staph. Depend, again, how sick is your patient? Are there 4 blood cultures positive for gram-positive cocci and clumps, or is it 1 out of 4? Did it take 2 hours to grow or 8 hours to grow to become positive, or did it take 36 hours to grow, etc. So some things to consider. And then for kind of a last example, what do you have in mind when we talk about gram-positive boxcar or large gram-positive bacilli, let's say if it's a sample of necrotic tissue? So something like Clostridium would be described as a large gram-positive bacilli, specifically a boxcar in shape. Any questions so far? So that's the gram, but the idea is always to correlate the gram to the culture, and again, put everything in a clinical context, of course. So let's look at an example. If we have a superficial swab of an arm lesion, and we have 4+ polymorphonuclear cells, or neutrophils, 2+ epithelial cells, and 3+ mixed morphotypes, and that's what's seen in gram, and in culture you get no growth. So what are the potential reasons, or how would you potentially explain this, what you see culture or gram and culture? Any brave folks?
They'll just be in normal form.
But you have no growth. So why do you so you clearly have a lot of organisms that you see on the gram, but you've got nothing in culture. Yeah, absolutely. So anaerobes was one of the questions. Absolutely. So again, this is it pays to know the limitations of the microbiology workup. And for superficial swabs, these are they're not deep abscesses where anaerobes would likely be potential pathogens. These are just superficial swabs of lesions. They're not set up for anaerobic culture, so we would never look for them, and therefore we would never report on them. So they all could be anaerobes. And the other question, if you remember, that the gram smear shows us microorganisms, whether they are alive or dead. It's a snapshot of that picture in time, whereas the culture, you need that organism to be alive for it to grow on the plate and show up as a colony for us to work up. So is this patient on appropriate antibiotic therapy? And the swab was taken just to make sure that we've cleared, or we're getting better, or that the antibiotics are working. So yeah, maybe that's effective therapy right at work. So again, something to keep in mind, and always rely on that patient clinical presentation and condition. What if you have a endotracheal suction, which shows no polymorphonuclear cells, 3+ epithelial cells, and 2+ mixed morphotypes, and 4+ gram-negative diplococci are seen? So if you remember back onto the gram slide, or when we talked about the gram IDs, when we talk about gram-negative diplococci, you would think of something like Moraxella catarrhalis or Neisseria meningitidis as being potentially a pathogen. But your report only says, normal flora. We found no pathogen. So how can what's going on there? It could be antibiotics, right? We talked about that you could effectively have eliminated the pathogen. That's why there's only normal flora. But what else about the gram makes you think that it's actually okay the way that it's growing? Yeah, so the no pus. The fact that there's no pus on an initial specimen means that, yes, there might be increased secretions that you're worried about, but there is no inflammatory response. So could this be just another etiology, a non-infectious etiology for whatever the increased secretions are due to? Absolutely. So with no pus, it's normal for Moraxella catarrhalis to live in our respiratory tract, and Neisseria meningitidis, but it might not be causing an infection. So that's normal flora. And there are other gram-negative diplococci, other Neisseria species that are part of normal oral flora, which then that's why that is reported that way. Does that make sense? Right. The other thing that you may have seen on the micro reports is bacteria are reported, and in brackets, the comment of some being intracellular is present. And basically, that just means that the bacteria are actively engulfed by the white blood cells, and it points to the significance of the organism as the likely etiologic agent of infection. So just to illustrate an example of that, you have a skin swab of an ankle wound. It's filled with pus, 4 plus pus, 4 plus red blood cells, 1 plus epis, 2 plus mixed morphotypes, and you have 2 plus gram-positive cocci, some of which are intracellular. And then in culture, you have 2 plus mixed skin and GI flora, and 3 plus streptococcus aeruginosus is isolated. So those 2 gram-positive cocci here have been singled out because before you as you wait for cultures, the only thing you have is that gram, and it shows you that, yeah, it could be part of the mixed morphotypes, but the body's telling you that they're being attacked preferentially, and so that those gram-positive cocci are likely, in the setting of a mixed bacterial flora, they're the ones that are probably the causative agents of infection. So that's why streptococcus aeruginosus is being worked up and reported, and likely the causative agent of infection in this case. What happens if you have the same gram, except with 3 plus mixed morphotypes that are reported all being intracellular? And on the culture results, you have mixed skin and GI flora reported. What are your thoughts about that? So you have 3 plus mixed morphotypes, and with the some intracellular comment, and culture shows only mixed skin and GI flora. No particular pathogen. So often, this is then further amended by one of the technologists or microbiologists to say that, hey, we see multiple things, or the white blood cells gobbling up multiple different morphotypes of bacteria. So it's not just one type of bacteria that's causing it, but actually it might be a polymicrobial infection. And this is not uncommon with diabetic foot infections, right? Because they're known to be polymicrobial. And this is exactly what the body or the gram illustrates, is that multiple bacteria are being perceived as pathogens and targeted by the white blood cells. So there's no point of us trying to work up everything and give you susceptibilities for every single organism isolated in culture, because there might be 5, 6, 7, 10 sometimes. Instead, approach it from a polymicrobial type of infection and treat accordingly with broader spectrum of antibiotics instead of targeting it towards one particular organism.
And even Monday, people should be out.
So what happens when we have a deep wound, let's say a tonsillar abscent, the patient is not on antibiotics, and you have 4 plus pus, 3 plus mixed reported, and there is a predominance of a gram-negative bacilli.
That's right. This is Scott from
On
the
culture, what you
general.
get is after 24 hours, you just have 1 plus E. coli reported.
Hi,
What
Pasqua.
with that?
Hi, this is Scott from the general.
Yeah.
Anyone
right?
out
So
there
anaerobes,
who has their mic on,
take longer to grow. They're more
please mute your
insidious.
mics.
That's why you wouldn't necessarily see anything worked up or anything shown in the first 24 hours of the report.
Right away. Yeah, we need to
So
know.
after 48 hours, you have 1 plus E. coli and you have mixed anaerobes.
I think because she was away, right?
So from that report, if we were to take it at face value, without understanding what the pathophysiology of a tonsillar abscess may be, we could have interpreted it as the E. coli being the pathogen. But in reality, not only are the 4 plus anaerobes predominant, but based on the gram, if you see here, what was in the gram was, we saw a predominance of fine gram-negative bacilli. So this is what an E. coli looks like, which was not predominant in the gram. And again, this is what likely was seen in the gram, reported out or described as fine gram-negative bacilli. And that points to the anaerobe, such as Fusobacterium, which is the culprit of tonsillar abscesses in most cases, being reported and being worked up.
Well, you can write anything here.
I will skip that. And again, for the interest of time, we'll go to try a few cases. So let's start with the micro report and work our way backwards. This is just from infection, for a bit of infection control chronic relief. The patient in the next bed is highly infectious, but thank God for these curtains. So we have a swab of a right hip, and the gram shows 1+ pus and 4+ mixed morphotypes, with culture showing kind of a mixed GI flora picture and positive culture, and specifically for Acinetobacter baumannii and Pseudomonas aeruginosa reported out with a susceptibility. So the patient has been started on Piptazo. What, or how would you interpret that? If you're the pharmacist coming in, or you're the physician following up your colleague, how would you feel about that?
During college patient will be using bathroom.
Do we know more about the culture? Like, is it a surface swab or is it from like a?
Yeah, it's a surface swab. Yeah.
Okay.
So again, what on the gram might you think that it might, that might tweak you to think that, hey, is this really an infection? Did it look infected? Obviously, you would lay your eyes on the patient, right? Again, going back to that clinical setting. Is it purulent? Is it hot? Is it red? Is it tender? Does it actually have those clinical features of a skin soft tissue infection? Or is it just a chronic kind of poorly managed wound that somebody swabbed? So to me, I look at that, again, boiling it all down to the clinical content, but with 1+ pus, it's not really that purulent. So is it really infectious? And there's a bunch of stuff. So has it really been debrided, has it been managed, or has it just been, a chronic abscess? And remember, these patients in hospital are coated with fecal flora, unfortunately, fecal veneer. And what is actually normal flora for them is much different from a fully functioning, highly functioning outpatient who takes baths every day and does good personal care. Again, with mixed flora, GI flora being predominant, Acinetobacter baumannii and Pseudomonas have been reported just because they are potentially pathogens, but it's up to you to then take a look at this clinical setting, in a clinical setting, and say, well, this doesn't look infected to me. And these are environmental organisms, Acinetobacter and Pseudomonas. They're part of the kind of normal flora of a lower leg or, below the waist. And so, again, are they truly pathogens? And should we be starting Piptazo? Or should we just watch and wait, debride, resubmit a better swab, and then reassess if you believe that it is an infection? Yeah.
Whoever is participating via telehealth or WebEx with an open microphone, please mute your microphone. It's very disruptive.
See, this is the only write-up that we have.
So another example here. So we have a gram. It's a toe tissue, and it's 2+ pus, no epithelial cells, no organisms seen in gram. And culture shows coagulase negative staphylococci with the comment, please contact microbiology if further workup is required. So what do you think? We've worked up coagulase negative staph because it is a tissue, and you don't know whether it's a tissue that has been obtained after a debridement or a biopsy, or so it's worked up, and you are now interpreting this information. So how would you interpret it? Would you care about coagulating staph?
And if it does, because it takes their time.
No. So based on
information.
Based on what, I guess, would you make that decision? Just the fact that it's coagulating staff. I guess that's a good place to start. But is the gram supporting you in that, or? Yeah, so the gram, there is purulence, but you really have no organisms seen. And so there needs to be about 1 times 10 to the 7th of organisms for them to be picked up on a gram. So it's not saying that you don't have truly any organisms present, but if you don't, then the bioburden is not as great as if you have 4+ Staph aureus or gram-positive cocci seen in gram. And so again, not that purulent and no organisms seen with a coagulase negative staph. If this was a bone biopsy, or if this was a prosthetic device associated infection, then coagulase negative staph could be important in this setting. So again, don't take things at face value. Put it back in the clinical context of the patient. Quickly, just talking about UTIs, just because they, I think, play a huge role for antimicrobial stewardship, as they're the most commonly obtained specimens, highest volume of specimens submitted to the lab. But there's a lot of misconceptions about urinary tract infections and UTIs. And the number one reason that staff collect urine is unfortunately still because the urine is cloudy and it's foul smelling. I would urge everybody to take a look at their own urine and tell me when is urine not foul smelling. It's meant to be foul smelling. It's cleaning your entire system of stuff. And, depending on the foods that we eat, whether you had asparagus, it's even going to be more foul smelling, or whatever else you have eaten. It's going to be cloudy depending on a number of different factors. So don't equate foul and cloudy smelling or foul smelling and cloudy urine automatically with a symptoms or signs of a urinary tract infection, which is a very hard thing to do for many people because it is a cultural change, but that's what we absolutely have to do. UTIs are very, I think, difficult. UTI infections are very hard to diagnose, but there are ways, again, don't just take a report at face value, put it back into the clinical context of the patient. Patients who are asymptomatic from the genitourinary perspective are well known to have asymptomatic bacteriuria that should not be treated because it does them more harm than good, and that's been well documented. And it's important for you to know that the urinalysis, it's not really useful when it's positive because I said, many things can make white blood cells appear in your urine. So it may be positive for other reasons than just infectious etiology. But when it's negative, it is awesome. It is 100% predictive of something, of no UTIs. So if you have a negative urinalysis, go look for something else if you're worried about infection. So it virtually rules it out. So let's have an example of that. And this is an actual example where Pseudomonas at 10 to the 7th was recovered in pure culture from a 9-month-old, and susceptibilities were provided. And of course, ceftazidime, piptazo, and Tobra, IV choices only for these antibiotics, no oral. And the MD phoned to say, well, there are lack of oral treatment options. So if it was you receiving that phone call, what kind of questions would you pose? How sick is the patient? Absolutely. And to my surprise, the answer was, oh no, he's fine. He's fine, but I see a Pseudomonas in this urine on a 9-month-old. I mean, my goodness, it's a pathogen, isn't it? I've been conditioned and I've been taught that Pseudomonas is a pathogen. Absolutely, but go back to your patient. Is he symptomatic? The child was completely asymptomatic, and this was collected for routine workup, etc. I'm not quite sure, but at the time that I had the conversation with the physician, completely asymptomatic. So why was the urine collected? What are the current symptoms? Nothing was the answer. So again, yes, it is a pathogen. We reported it because we assume that the patient has symptoms of a urinary tract infection, and absolutely, you can have a Pseudomonas causing a urinary tract infection, absolutely. but in the setting of symptoms. If you have no symptoms, then they're probably just contaminated the urine with Pseudomonas, which is part of that area. And in general, I mean, it's an environmental contaminant or commensal, and it can contaminate even a well-obtained urine. So don't take reports at face value. What if you have an indwelling calf urine that shows, mixed morphotypes, very heavy 10 to the 8th growth, and the microbiology technician tells you that there are at least 5 things growing. We have Pseudomonas, we have Enterobacter, Enterococcus, a coagulase negative staph, and a Serratia. So which ones are causing the UTI? I mean, yes, this is a catheter-associated potentially urinary tract infection, which we know can be polymicrobial. But come on, 5 things? What's going on? There's pyuria and bacteria on urinalysis. Again, as we discussed, that might not be meaningful. There are other reasons for pyuria and bacteriuria. This is a patient who's been chronically catheterized, and the only thing that the nursing staff was worried about, that's why they obtained this urine, was increasing delirium. And the physician calls and says, well, can you just work up the pathogens? So in a setting, I mean, Pseudomonas is a pathogen, Enterobacter, Enterococcus, Serratia, and even coagulase negative staph can rarely be a pathogen. So it's not meaningful if we provide a report with all these different susceptibilities. And it actually will do the patient harm, because I bet they will try to find the right antibiotic combination with these organisms would mean that the patient might end up on 3 or 4 different kinds of antibiotics, which is, again, not something that we want to do. It's hard to diagnose UTIs, absolutely, but I think it's making sure that you get the absolutely best specimen possible. So if this is an indwelling catheter, ask the nursing staff to pull that catheter if they're concerned that there's a urinary tract infections, and obtain a urine sample with a new catheter. These bugs are so great at forming biofilms that within 20 minutes of catheter being in place, those bugs are back on it and colonizing and making it their nice cushy home. So 20 minutes is all it takes for bugs to basically colonize and permanently stick to that piece of plastic. So the only way to actually obtain a urine that would be then clean is to try to get in through an in and out cath, or immediately upon the insertion of a new catheter. And UTI, I would venture to say that they should be, for the most part, a diagnosis of exclusion, especially in the setting of long-term care patients, a trial of hydration, reconciling their meds, checking for infection at other sites that would explain the reasons for their delirium, as opposed to automatically jumping the gun and saying, oh, it must be a UTI. And just maybe last quick case before you guys, I open the floor for questions. So again, we have stool samples from a mom and her 11-month-old, and these stool samples were sent for C. diff and culture. So on day 1, C. diff results are back because they're done by a molecular technique, so they don't need a culture, they just get tested, and so they're back. And mom is positive by a PCR, and the baby's stool is not done for C. diff because babies are not tested for C. diff. That's another story. If you'd like to know more, I can definitely tell you about it. But that's been rejected, and the culture is still pending. So, this information is received by the MD, and he calls me and says, well, can I use metronidazole to treat C. diff in the mum? And so, is that appropriate, is my next question. So if that was you on the phone, and you have a physician who has a positive C. diff result, what would you advise, or what kind of things would be going through your mind? So the diarrhea has been going on for 2 weeks, and he's got a C. diff positive result. What's going on? Perfect. So what do we know about C. diff? C. diff is basically a result of a disbalance of the normal flora. So C. diff, up to 20% of patients have C. diff as part of their normal gut flora, except that it's kept in balance with the normal flora around it. When we take antibiotics basically act to kill off the normal flora, giving C. diff plenty of room to replicate and reproduce in, and then obviously producing diarrhea because of the toxin production that they do. And so, exactly, have they been on this antibiotic that then would push them over and deplete that normal flora that keeps it in check? What is interesting is that on day 2, the culture actually, the stool culture is actually positive for Campylobacter jejuni. And how do you fit all this into perspective? So do they have C. diff? Do they have Campylobacter? Do they have both? Like, what's going on? How would you interpret that?
No step.
Yeah, so no C. diff. I would say no. And from your discussion, say, oh no, they have not been on antibiotics. They're fine. They went to a country fair and ate something and whatever and got sick after that, and they just haven't been able to get better. So with no antibiotics on board, and it's not to say that C. diff can't occur because of other reasons that produce a disbalance of your gut flora, but majority of it is antimicrobial associated. Really what happens is that this PCR test detected a normal bowel flora resident, which C. diff is. It came up first, so the physician automatically assumed that that is what's causing the diarrhea. However, the true pathogen is Campylobacter jejuni. Does that make sense? So, and I think that's all we've got time for, and I want to leave some time for questions if you have any. How about we take questions from the remote sites first, and then we can... Anybody on the WebEx or video conference? They may have disconnected, or...
There's some that are still logged on.
Okay.
So on the site, some of the WebEx are disconnected.
Okay.
But if there are questions, that opportunity to the remote sites?
Yeah, so if there are no questions from the remote sites, any questions locally?
Pasqua says they're good.
Oh, Pasqua's good, okay.
I'm sorry, the general.
General, yes. Mm-hmm. Anybody here for questions? So do you find that you have, problems kind of interpreting the micro report and have to, or are asked to say, well, what would you do as the prescribers, right? And I have to say that I'm very happy that the treatment decisions are being made in more of a kind of a team context, because physicians are recognizing, I think, that they may not have the necessary knowledge or the comfort level with antimicrobial prescribing, which is great. They're realizing their limitation, but also I want to put it out or float it out there that if you do have questions, we're always available for phone consultation, and we might not have all the answers, but we can at least talk about it. But again, a patient, if I'm sitting in the lab and advising or talking about it, the only way that conversation can be meaningful is for us to have as much clinical information as possible. Otherwise, it's just one blind person reading another blind person. So if there are no questions, that will be all. Thank you.
Thank you, Kathy.